All right, so we're going to we're going to just go back and go through the steps of rhythm recognition. We're going to look at the treatments for your more common. We're going to look at the algorithms. And we're going to do a couple of case studies. The case studies, you will find out, are very similar. If y'all remember us doing this review is very similar to the one that we did in, I guess, May of last year or April of last year. However, I think one of the discrepancies that we found this year with us following you guys through, and especially for myself, having more of a hand in this paramedic class than I did in the last one, is the fact that I feel like we hit cardiology. By the end of that semester, you guys could recognize your rhythms, you could treat your rhythms. Then we went into medical and trauma, and I tried to throw in some cardiac stuff, but we didn't do enough. And so here comes the last semester, and we're throwing out static to you, we're throwing out dynamic to you, and you've got all this other information that you've had in between the spring and now, and it's been a minute since you've looked at this stuff. So, I know with myself, going forward, in future classes, we will be consistent with cardiology stuff. Because, again, it's going to probably be the most important foundation that you can have for medic school. So, all right. So let's just go back and take a step back and look at quick review of the anatomy and physiology of the heart, and then the cardiac physiology and electrophysiology. All right. So let's go all the way back. The heart is about the size of what? Your fist. A heart has how many chambers? What are the top two called? What are the bottom two called? If I had a drop of blood that's coming in from the right side of the heart, making its way through the heart, where's the first place it would go? What valve would it go through between the right atria and the right ventricle? Tricuspid. Try to do right. Always try to do right. So your tricuspid's on your right side. Then it goes into what?
Right ventricle.
Right ventricle. All right, so let's back up just a minute. So we're pumping blood from the right atria to the right ventricle. We got all this blood is pretty much being drained by gravity, because we know that the atria is not as muscular as the ventricles, right? And so when that blood goes down, is all of the blood going out of the right atria? So what happens with the right atria and the right ventricle to further fill the ventricle? The atrial kick, right? The atrial kick. So it'll pump that last 30% of blood from the atria into the right ventricle. The blood coming back to the right side of the heart can also be known as what? Preload, right? All right, so let's move forward. We've got the right ventricle. Now we're going up through which vessel? All right, so you've got your what valve? All right, your pulmonic valve. Then it goes into the pulmonary, which is the only artery in the body, in the adult body, that what? Carries the oxygenated blood. At that point, from the pulmonary artery to the lungs, we've got what? What happens with the blood and the oxygen? We've got gas exchange. So this is deoxygenated blood, right? So we're sending the CO2 out, and we're bringing what in? All right? That process is called external respiration. External respiration. All right? So the blood is at the outermost point that it can get outside of the body, at the capillary and at the lungs. All right? So we pick up oxygen. Now where are we going?
Back to the pulmonary vein.
All right, back to the pulmonary vein, which is going to carry what type of blood? Oxygenated blood. within the pulmonary structures, the pulmonary vessels, you've got a pressure that is not your blood pressure, but is your pulmonary pressures, right? So that would be the location of things like pulmonary hypertension, right? Where you've got a high pressure in your pulmonary artery or your pulmonary valve, okay? That's also the site where pulmonary embolisms occur. So you leave the pulmonary vein, goes into the left atria, then it goes through the mitral valve or the bicuspid valve. Mitral has an L at the end of it, right? So you can think mitral left on the left side into the left ventricle. Of the two ventricles, which one has to work harder? The left side. Why? It's the pump to the body, right? It is the producer of cardiac output. What is, I just heard somebody say it, so it has to overcome that systemic vascular resistance, which is the pressure in the rest of the vascular system that the left ventricle has to overcome to get the cardiac output to the rest of the body, right? So it leaves the left ventricle, hits the what? Aorta, goes to the aortic valve, to the aorta, and then it transports blood to the vessels, to the cells for what type of respiration? Internal. The cell is the very most internal part of the body. All right? So, that's kind of a talk on the mechanical function of the heart. But we know that the heart has two functions in order for it to work appropriately, which will make sense when you get into some of your rhythms, some of your situations like pulseless electrical activity and systole and things like that. So you've got your mechanical function, and then you've got your what? Electrical function. So in order for the atria to be able to pump, they've got to be stimulated, right? The myocardial cells have to be stimulated by electricity. Where does that stimulation originate from in a healthy heart? The SA node. The SA node is known as the primary pacemaker for the heart. The SA node fires at an intrinsic rate of what? 60 to 100. So normal heart rate 60 to 100. Anything below 60 is what? Bradycardia. Anything above 100 is tachycardia. With that thought in mind, remember, there's no person that's textbook. There's no one person that's textbook. My resting heart rate, because I'm very athletic, may be 55, right? Or you got a person that has taken Adderall today and is all jacked up on Mountain Dew, and their resting heart rate might be 110, right? So the bottom line with all of our treatments, and when we're going to get to treatments, is to do what and not what?
Treat the patient, not the monitor.
Treat the patient and not the monitor. All right? Hey. Who's doing that?
Look at my test, Barry. It's next door.
Did you do that? I was too. I was like, what? What make you doing this? Quit it, quit it, quit it. I started to get this.
All right. I'll throw up the white flag.
If you'll tell me how to do it by my phone, I'll do it by my phone.
You have to download stuff and all that.
Well, then I'll see it by my computer. You have a bigger class. You walk around.
You can't do it either. You'll start doing ours.
It was clicking ours.
I won't use my thing.
It's the clicker.
I'll hit the mouse instead.
Or you can just tap the board.
Are you sure?
But then this is going to change
I
yours.
need to write a lot of stuff anyway, so I'm good.
So pull out the receiver.
Got it.
I was about to go upside somebody's head.
That's what it was. I was like, geez, am I gonna go?
Well, I knew it worked like that with the clickers. I mean, with the little things that we used to do. So anyways, so let's move forward. SA node fires. Boom, bam. We've got electrical current. 4 states of a myocardial cell that allow for this to happen. Well, a couple of those states, but four states of a myocardial cell that are different than any other cell in the body. What are they? Automaticity, contractility, conductivity, and excitability. So the excitability kind of works against the myocardial cell sometimes, which means that they can be influenced by an outside stimulus, right? The automaticity will work against a myocardial cell sometimes when it gets, when it decides it wants to become the chief and start pacing the heart on its own, and then the next guy says, hey, I want to pace the heart, and the next guy, and so they all start generating their own electrical activity, and then we have a lot of issues, right? The conductivity is where you can kind of imagine the electrical system of the heart like a power line system, right? Which just means this myocardial cell has ability to create its own stimulus. This one is going to conduct that stimulus to the next one and the next one, all the way down, right? And then contractility means it's going to receive that stimulus, so it's going to be zapped, and then it's going to contract, right? But in order for the heart to work, it has to be a beautiful displayed orchestra of everything working together, right? So the SA node fires. The SA node is just located on the right side, right? Does the right atria contract and then the left atria, or do they contract in unison? So it fires and it goes down your tracks, down the internodal atrial pathways, right? So it allows the heart, it allows the atria to contract together and the ventricles to contract together. Now each chamber is doing its own specific job, but they're working together, right? So then you get to the AV node. AV node is the site of a lot of things. A lot of your arrhythmias and things like that. So the AV node, if the SA node's not working right, it can say, hey, I want to pick up and start pumping. What's this intrinsic rate? 40 to 60. When this electrical stimulus hits the AV node, it says, all right, hold on, let me hold you just a minute. All right, now you can go. Why is that? To allow for ventricular filling, right? So if the atria just pumped everything in to the ventricles and that electrical current went all as one, then it's not going to give the ventricles time to fill. So therefore, you're going to have poor cardiac output. You hit the AV node holds it up, and then we go to the bundle of His. All of these are electrical nerve pathways, all right, that have the ability of the myocardial cells. Myocardial cells that transfer the electrical activity. The bundle of His starts here, and then it breaks off to your right and your left bundle branches. Your right bundle branch obviously is going to be focused on your right ventricle. Left obviously is your left ventricle. But they're just single pathways, and so they're not going to wrap all the way around the heart. So what picks up after that? The old Purkinje fibers. Now, SA node is out. AV node is out. Do your bundles, does your Purkinje network, does it have the ability to pace the heart? It does. But what's going to happen? It's going to be very slow, and it's definitely going to be a ventricular dysrhythmia because that's all that's getting stimulated. And your cardiac output is going to be severely compromised, right? Any questions? So, for our routine monitoring, again, I know that we're taking it back to the very elementary stuff that we learned. We're above this, but we're really not, because you've got registry coming up. So I want to make sure that you know how to read a rhythm strip. On registry, when you take registry, when you do static cardiology, don't expect every strip just to jump out and say, wham, bam, thank you, ma'am, this is what I am. You need to go through your steps so that you know that you know that you know that you got it right. What can a ECG printout tell you about the heart?
Electrical activity.
The electrical activity. It does not tell you how well the heart's pumping. It does not tell you if cardiac output is good or bad, i.e. PEA, right? We can have a sinus rhythm in PEA, but if the muscular function of the heart's not working, it doesn't tell me a whole lot, right? So how do we check mechanical function of the heart in the field? We're going to look at circulation, right? We're going to check for a pulse. We're going to look for signs of poor perfusion or good perfusion. Skin color, temp, mental status. All of it works together. So a single lead is basically what we look at when we run a strip. Usually go through what? Lead 2. And it's because of the way that the leads are set up. And we know that a lead, when it reads, it goes from a negative to a positive, right? So we have Einthoven's triangle with our leads 1, 2, and 3. And lead 2 reads from the right arm, which is negative, to the left leg, which is positive. So if you've got your heart right here, your SA node's sitting kind of right here, AV node, and your bundle branches, right? So we're going to get probably the closest look to the anterior, the outermost part of the electrical conduction system. Does that make sense? That's why lead 2 is usually the most reliable for just a quick look. A single lead can't tell you infar. It can show you STEMI in lead 2, right? But what do you need to do? 12 lead. Oh, it can identify axis deviation. I promise we're not really looking back at axis deviation. I think it's going to be a moot point at this point. I'm going to be a lot more focused more towards your treatment. Or chamber enlargement. It can identify right to left differences in conduction. It's just really showing you a posterior-anterior view. And then, of course, it can't show you the pumping action. All right, so remember your ECG components. You've got your P wave, your QRS, your T wave, and then in some situations you've got a U wave, which would follow the T wave. Although rare, it could occur. The U wave has been associated with electrolyte abnormalities, but sometimes the U wave just may appear as a normal part of the person's rhythm. All right? You got your intervals, your PRI. So your PRI is going to be from the time of your P wave, from the start of your P wave to the start of your Q wave. Which type of arrhythmias would we be looking for that we're going to be paying attention to a PRI? So your first degree and your second degree heart blocks, right? Then you've got your QRS. Your QRS, beginning of the Q to the end of the S, all right? Where do you find the end of the S? You look at the isoelectric line, and that's where you try to find it unless you've got some type of MI, right? So your S is going to end, and then from the point where your S ends to the point to where your T starts is your ST segment. What's significant about identifying an ST segment? MI, right? And then you've got a QT interval, all right? A QT interval. Oh, you're cute. A QT interval. So that's going to be from the Q to the end of the T. what would a QT interval show you? It's going to show you a complete cycle of ventricular depolarization and repolarization. All right? What would be the significance of a prolonged QT interval? All right? It could show some kind of block. It's going to be some kind of issue that's going to affect cardiac output, because a prolonged QT interval is going to mean that it's taking the ventricles longer to repolarize and depolarize and repolarize. The body depends on that quick depolarization and repolarization for the ventricles to produce cardiac output. There's certain medications that prolong the QT interval. All right? So, just really quick, the P wave is going to show you what? Atrial depolarization. All right? Do we need to go back and talk about D and repolarization? Everybody understand that? Depolarization, the contractile force of the myocardial cells. Repolarization, the relaxation. All right? QRS shows what? Ventricular. All right? And then your T wave shows ventricular. Why don't you see atrial repolarization? Because of the amplitude and the voltage of a QRS is a lot stronger than the atrial repolarization, so it's hidden. So your general rules in your rhythm recognition and your treatment of the patient. Number one, what is it? Patient, not the monitor. Patient, not the monitor. Read every strip, left to right. Try to at least get a 6-second strip. The 5-step method. Remember when you the first time you saw this slide back in January or February, you're like, crap, I'm never going to get this. Some of y'all may have been, yes, I've got it, but I know for a fact that a lot of y'all are like, this is just really difficult. You've learned how to apply the 5-step method, and now you're probably to a point where you don't necessarily have to do the 5-step method. But my strongest recommendation for you is when you're testing, go through them mentally. You don't have to write them out, but go through them mentally. Avoid shortcuts and assumptions. Sometimes if it looks like a duck, walks like a duck, quacks like a duck, it's a cat. Right? Case in point, last Wednesday, the first rhythm in static cardiology was atrial fibrillation with a rapid ventricular response. Everybody, well not everybody, a lot of you though naturally went to supraventricular tachycardia. But had you taken a moment to look at it and to look at the regularity of it, then you would have realized, hey, this is an irregular rhythm, right? That's what I'm meaning by just take a moment. Quick glance often will lead to an incorrect interpretation, and it could be the difference in your treatment. And at this point, we should be getting to where we've mastered the parameters of the dysrhythmia as far as doing the steps. So your step 1 is your heart rate. Step 2 is your rhythm, regular, irregular. Step 3, P wave. Step 4, looking at your PRI. And then step 5 is going to be your QRS. All of them are important, but start with your basics first. You need to get a baseline of what your rate is. Now, here's the thing. You've got to have each step to depend on each other, because you can look at a strip and get a heart rate of 160, but if I don't go to the next step and look at regular or irregular, I know, well, the rules are if a heart rate is above 150, then it's SVT, so I'm just going to jump into SVT. But if I look at the rhythm, it's irregular, then I know it's probably not SVT, it's something else. All right? Does that make sense? So your two ways to determine heart rate, the 6 second, I'm not going to spend a lot of time on that. 6 second. Look at your 6 second strip, count your QRSs, multiply it by 10. Your R to R. With the R to R, find an R wave that is as close to a big line as you can. Count your boxes. So we're going to say this is on that one, 1, 2, 3, Yeah, it's right at 4. So we're going to take 4 and divide by 300. 300 divided by 4 is what? 75. 1, 2, 3, 4, 5, 6, 7, 8. So 80. So I'm close in that range. Does that make sense? So your rhythm. We're looking to see, is it regular? Is it irregular? And if it's irregular, is it showing a predictable irregular pattern? All right. PVCs. Bigeminy PVCs. I'm predicting that after each QRS, there is going to be a PVC. So that is a predictable irregularity, right? What about if it's irregularly irregular or non-predictable, as Ms. Curry called it? Atrial fib is a common one, right? You don't know when that QRS is going to hit, right? So you can't predict it. Your P wave. So naturally we're looking to see, is it upright? Is it upright? Is it rounded? Does it look like a normal P wave? Is there even a P wave there? Or is the P wave inverted? Looking at your PRI needs to be between what and what milliseconds? 0.12 to 0.2. All right? Look at the onset of the P to the onset of the Q. Then your QRS complex. Your Q wave, your first negative deflection. Now what is significant? Do y'all remember what is significant about a Q wave that is 2/3 the length of the R wave? If it's negative downward. It's evidence of ischemia. It could be an old, but we know that when we have a QRS, when you have a Q wave, so there's my P, there's my Q, we know that we don't want it to go very far down. Alright, it looks more like, I don't know. Alright, so we know that we don't want a real far deflection. If it goes down further, that is evidence of some type of ischemia or some type of cardiac issue. Alright, and it may be old. Your R wave, should be your tallest, and it should be your positive deflection. So anything above the isoelectric line is positive, anything below is negative. And then your S wave, sharp negative downward deflection. So it's your Q, your R, and your S is coming down. Then we're looking at the isoelectric line. If it meets back at the isoelectric line, that is the end of your S wave. Okay? So your ST segment, you're looking for your J point. J point. The J point is where the S and the T, is where the S is going to meet the T, start for the ST segment. Sorry. All right? So your J point. So this is really what we're looking for as far as elevation or going below the isoelectric line. All right? Y'all follow me? All right? Then T wave is your ventricular repolarization. U wave, we've talked about it. Usually not visible. If it is, it may be as the effect of some type of electrolyte abnormality, or it just may be there. All right? I'm not going to do a whole lot with the U wave, but do know that there is a possibility of a U wave. All right? Artifact. There's 4 causes. Most common cause of artifact, as you've seen on the back of an ambulance, is that patient wiggling around, right? Or a loose or defective electrode, also called a fuzzy baseline, often because it's on a fuzzy patient. Improper grounding. This is going to be where you have 60 cycle interference. Have y'all ever noticed that, and it especially occurs when we use the mannequins, if those lead wires are touching something, that a lot of times that'll cause some type of artifact, and it's because it's picking up on the electrical properties around it as well. And then, of course, faulty EKG apparatus. So, the first thing you do, if you see artifact, get them to hold still. Second thing you do, check your leads. Third thing you do, look and see if your lead wires are connected appropriately, and look around to see if is there a radio or is there something that could interfere. If there's a radio, like ETS has radios on the back of their ambulance, if you see a lot of artifact that you can't change, turn the radio off, because sometimes that interferes with it. All right? And then lastly, check your equipment. All right? So that's a quick review just on your rhythm strips and looking at them. We're going to move on into treatments. Do y'all need a break or y'all good? What? Break? All right. I got 10:45. Be back at 10:55. Let's move on into treatment. What's the whole reason why we treat an arrhythmia? What? Because it's not normal? Well, I'm not normal, but I don't receive treatment every day. Okay, to improve cellular respiration, external respiration, so improve perfusion. What role does the heart play in perfusing the body? It's the pump. It pumps out cardiac output, right? We have cardiac output. So the bottom line for us to treat an arrhythmia is the fact that it's affecting cardiac output in some form or fashion. The electrical and the mechanical is not doing what it's supposed to do in order to perfuse the body appropriately. Now, there's several different repercussions for that, or several different reasons for that. And so there's different ways to treat different cardiac problems, but your end goal is the same for all of them, and that is to restore cardiac output. You need the pump to pump efficiently, right? You need the pump to do what it is designed to do. All treatment is initiated with the intent to improve cardiac output. So your intent to treat SVT, or your intent to treat sinus bradycardia, is to improve cardiac output by fixing the arrhythmia, right? By giving medication to get the heart to start working normally again. Several different factors, or really two main factors, that affect the heart when you have an arrhythmia or you have some type of cardiac issue. It's going to either affect your heart rate or your stroke volume. Your stroke volume and your heart rate together, working together, is what gives you good cardiac output. So you can go through all the algorithms that you want, and you can look at it, and you can try to dissect it down to this has got an aberrant pathway here and a re-entry mechanism here, and I need to work on this bundle branch and work on this node and all that. But you can also just take it back to the basics when you look at your rhythm. Is it moving too fast? Is it moving too slow? Or is there something else that is affecting the heart, and is it not moving? So is it too fast, too slow, or is it moving? Now that can talk about the heart itself, the heart rate itself, or the amount of blood that's being pumped out of the body, or out of the heart. Not out of the body, that'd be bad, but out of the heart. Are y'all following me with this? So when we look at a rhythm, of course we're going to do our 5 steps, but when we decide how we're going to treat it, we're looking at this. Is the heart itself pumping too fast or too slow? Is the blood coming out of the left ventricle too fast or too slow? Or is it moving at all? Because we need to restore cardiac output. We need to get that blood circulating to the body. So we look at our rate. That can tell us is it too fast or too slow. If we've got a normal rate, then what other factors are affecting it? What other factors are affecting cardiac output? Does that make sense? So let's look at some of our too slows. You got a bradycardia. Your algorithm. Bradycardia with a pulse, right? If they've got a pulse, we're going to that algorithm. Don't make it any more difficult than it has to be. You know that on all patients, you're going to check a pulse. You're going to look at their overall appearance. We're going to put oxygen on, right? And then we're going to try to do medication therapy. And if that don't work, we're going to electrical therapy, all right? So you've got your pharmacological interventions and you've got your electrical interventions. Your pharmacological interventions are all your antidysrhythmics, all your different medications. Your electrical therapy is TCP, defibrillation, and cardioversion, right? Now, the thing that you really have to think about is, am I going to jump right into pharmacological interventions, or am I going to jump right into electrical interventions? All right? With your bradycardias, your medications, your basic, if you're treating a bradycardia according to American Heart Association in the field, it's going to be your atropine, your dopamine infusion, your epinephrine infusion, right? That's the only medications that show up on that algorithm. Can y'all think of any other medications that you would throw on there? Not if I'm going by AHA guidelines, right? And then our electrical therapy would be transcutaneous pacing in the field, and then if they go to the cath lab, before they actually insert a permanent pacemaker, they're going to run wires up and they're going to do transvenous pacing. All right? So, what's going to fall under this? Your sinus brady with a first degree AV block. And now, although your heart blocks are not necessarily bradycardic rhythms in themselves, the treatment's still the same. So that's why we're going to go under the bradycardia algorithm. Now, there is questions about atropine with your heart blocks. If you're following the algorithm, it's going to take a minute to hook up your pacing and all that. It's okay to give atropine. However, what do we know about atropine? It's not really going to do a whole lot for the heart block, but now if there's some type of SA issue, you could go ahead and start hitting on that, right? The AV, the atropine is not going to really affect the AV node, all right? And that's where your high degree heart blocks are. Well, that's where all your heart blocks are. Your AV blocks, this was a big thing that everybody kept saying we were having some issue with looking at the AV blocks, especially the high degree. Can't spend a ton of time on this, but I do want to refresh you. All right, so there's two ways of differentiating AV blocks. Number one is classified by its site at the AV node or the bundle of His, or below the bifurcation in the Purkinje fibers. All right, so your first degree, second degree, third degree heart blocks are going to fall under the AV node. Your bundle branch blocks, and then your infranodal blocks are going to, your bundle branch blocks are going to fall under your bundle of His, and then your other blocks, your hemi blocks, are going to fall under your under the bundle of His at the Purkinje fibers. Okay. So the whole thing with a block is that there's your SA node, there's your AV node, then your bundle, then your Purkinje fibers. So the whole thing with blocks is that there's something that is slowing conduction at the site that it's trying to get through. So with your AV blocks, starts at the SA node, goes here, there's something that's slowing conduction there. Alright? Your first degree, your electrical stimulus starts, it slows it down more than what it needs to, but then it finds a way to go through. Right? Your second degree, type 1, starts at the SA node, goes through. First time, slows a little bit, but goes fine. Second time, it holds it up for a little bit longer, then it goes. Third time, it goes through, holds it up for even longer, then it goes through. Fourth time, blocks, bam, we got to start over. Alright, so that's why you've got the prolonging P waves. Alright, your second degree type 2. Starts here, comes down. Alright, it's going to let me go through. Next heart starts here. Nope, not letting me go through. It's going to go through. Nope, not going to let me go through. Alright, does that make sense? Then your third degree. Your third degree, your electrical activity is kind of hanging out and doing its own thing in its own house. Alright? So the EKG monitor is picking up your P waves, but they're just kind of hanging out. They're firing, and they're showing up on the P wave. Alright? Then here, nothing's going through here at all. So the ventricles are going to pick up, and they're going to fire themselves. They're going to say, okay, you do your thing, I'm going to do mine. You do you, I'm going to do me. Right? So then you see your ventricles here, but when the atria fires, you see a P wave. When the ventricle fires, you see a QRS. Alright? Then it may be there, and then it may be a little bit longer before you see a QRS. But basically what you're seeing is the atria doing its own thing, alright, as evidenced by P wave, and the ventricle doing its own thing. Sometimes they may mesh up and go in together, and it looks like a normal complex, but most of the time there's going to be just no relationship between the atria, or the P wave, and the QRS. Now, that makes it easier to understand for the physiology, but how do you recognize it? How do you recognize this heart block? The best thing to do is look at your P waves first, then look at your QRSs. If your P waves are regular and your QRSs are regular, but they ain't married together, they're just out partying doing their own thing, then more than likely that's going to be a third degree heart block. Well, that didn't work. I'm glad it didn't break that expensive computer. So you got your first degree, your type 1 second degree, which is your Mobitz or your Winky Bop. Your type 2 second degree, that's your Mobitz 2. There's this 2-to-1 AV block, don't worry about it. You got your third degree AV block. Alright, we just talked about them all. Remember, your type 1 is your widening. Alright? Type 1 is Winky Bop. Think of Winky Bop as being the longest word out of those two, and think, oh, Winky Bop is a long word, so I've got a longer P wave. It's widening out. Alright? Just made that up on a whim. Hope it don't screw y'all up. Alright? Then your type 2, you're going to see some P waves, but no complexes, and it's going to be a little bit more often occurring. All right? Treatment for your AV blocks. Your first degree AV block, rarely treated. You could put a monitor on me right now and I may have a conduction delay. But if I'm not showing any signs of hypoperfusion, don't treat it. More often than not, if you see a symptomatic patient with a first degree AV block, they're probably going to be in a sinus bradycardia. All right, so we're going to treat the bradycardia. Your Mobitz 1, you're still getting complete complexes. Every now and then you're going to have one drop off. So more than likely you're not going to have much of a delay in perfusion. So those are rarely treated. If you've got significantly reduced cardiac output, as evidenced by patient presentation, blood pressure, perfusion status, skin status, mental status, then of course we're going to go into the bradycardia algorithm and start treating. Your type 2 and your type 3 are your highest degree blocks, and they're potentially the most fatal. All right? You can't rely on atropine if you've confirmed that it is a block, a second degree type 2 or a third degree. You cannot rely on atropine. Not saying you can't give it, but you can't rely on it like you could if it was just a bradycardia. So what is your treatment of choice? We're going to try to take over the pacemaker ourselves. We're going to try to make the heart do what we want it to do by shock therapy. All right? If they're hemodynamically unstable. Goes back to treating the patient, not the monitor. All right? I'll get you next time. So here goes this. This is that thing that I had posted on Facebook a long time ago. I think it's like on Valentine's Day. Yep. So heart blocks are like relationships, and try to remember little quirky things to help you remember. All right? Everybody was expecting me to kick up when we talked about the atrial kick, right? Little quirky things to help you remember. First degree AV block, the P and the QRS, they're married, they have an argument, and they're keeping their distance, but they're still married, right? Only like that. Your first degree AV block, P and the QRS have an argument, and they're keeping their distance. Oh, that's what I already said. Your type 1 second degree, the P and the QRS are in a vicious cycle of breaking up and getting back together. They argue. They keep their distance. They keep their distance. They keep their distance. Then they're off. But then they start back together. Your type 2, P and the QRS decide to work it out because they have PVCs together. Ha ha ha. However, the P is still upset with the QRS and goes out a night or two a week and fools around. So they're there, and then he disappears. Or she. You know, nobody says that the QRS has to be a dude. And then your third degree, the QRS catches the P cheating, the P wave cheating, and moves out, and they separate, and they're divorced. There's no relationship. That's the way I've always learned third degree is a divorce. They are completely separate, doing their own thing. Biggest thing to remember about your blocks is you're treating your patient, not your monitor. If you recognize a high degree block, type 2, second degree type 2, or third degree, you've got a stronger potential for you to have severe cardiac output compromise. Okay? Make sense? Let's move forward. So, we talked a little bit about our too slow and our treatment, our too fast. Anything greater than 100. Treat your patient, not your monitor. Right now, I'm jacked up on caffeine. My heart rate's probably 110. What is important about tachycardia that's going to determine your treatment? If we've got to treat a patient, stable or unstable. That's one of the differences between your bradycardia. All right, your bradycardia, whether they're stable or unstable, we're still going to give medications and get ready to pace them. in your tachycardias, if they are hemodynamically unstable, we're going straight to what? Shocking them, right? Not killing them. That's not what I'm in the business for. I hope I don't kill them. If I do, I got the equipment to save them. So I'm a paragod, like Cain.
And Bo.
And Bo. Bo's just a sleepy paragod today.
He's right on
Right.
What is significant about a tachycardia as it relates to cardiac output?
Doesn't do enough.
Doesn't allow ventricular flow very well and doesn't push down the flow out.
What Kane said.
Yeah, what Kane said. So you're moving so fast that the blood doesn't have time to fill in, so it's pumping, but it's not pumping a sufficient volume out, right? It's Starling. It's Starling, darling. It's Starling's law, right? The longer the ventricle has time to feel, the more expanded it's going to be. We know that the myocardial cells have elasticity about them, so bam! Right? It's going to push it out faster. Right in your face. Alright? But if it doesn't have time to feel, it's just going to go really really fast, and it's just going to not push out enough volume, right? Way to work Starling in there. Serious signs of cardiac output compromise: decreased blood pressure. Alright, signs of cardiogenic shock, signs of pump failure. If the heart ain't pumping out, we're not perfusing.
Signs of neurogenic shock.
Why signs of neurogenic shock?
If the brain's not confusing the alternative state.
Okay. Fair enough. Probably not, yeah. Let's just go alter mental status on that.
That sounds good.
Alright? If I'm looking at signs and symptoms of a patient, deciding on what to treat with a patient, or how to treat the patient, what am I looking at?
Patient disposition.
Alright, patient disposition. So I'm looking at outward signs, but I'm looking at hemodynamics as well, our objective signs, right? If I've got a patient that has a tachycardia, but they're just a little dizzy, but they're still alert and oriented, they may be a little bit pale, but they're still alert and oriented, but their blood pressure is 110/80, I'm not shocking, right? I'm giving meds. But if I've got that same patient that's altered mental status, heart rate's 190, blood pressure is 70 and crap, I'm popping them. Make sense? Yes. So again, it goes back to your cardiac output. But tachycardias is going to affect both stroke volume and heart rate, right? Because we're going too fast, and it's going to affect our stroke volume. Every time the heart beats, we have our stroke volume. We have the amount of blood that's being pushed out. But if it's going too fast, we don't have time for the stroke volume to catch up. So your too fast tachycardias, AFib. That's going to be AFib with a rapid ventricular response. AFib in itself is typically not going to cause a whole lot of issue until the ventricles are trying to keep up with the fibrillating atria. As long as the ventricles can maintain a constant, they're going to be okay. But if the ventricles are trying to keep up with every time that the atria fires off, it's going to beat really, really fast. Okay? So you can have an AFib with a lower heart rate, or you can have AFib with rapid ventricular response, meaning the ventricle's trying to respond or keep up. Your A flutters. Again, if it's normal rate with A flutter, Not necessarily anything we're going to do in the field. If it's a tachycardic rate with a flutter, and we're showing hemodynamic compromise, we're moving forward. And of course, your monomorphic VTAC and your polymorphic VTAC. What is polymorphic VTAC? Old Torsades, right? Torsades. Now, I've got a patient with VTAC on the monitor. What's going to be the biggest thing as far as VTAC goes to tell me which algorithm to go with? There's a guided freaking pulse, right? Because you can have VTAC and still have a pulse, and we're going to either have to cardiovert or try to give some type of antidysrhythmic, right? Adenosine not going to probably work on that. Because adenosine, where does adenosine hit? Where's the site of SVT? Supra, above. It's super, it's above the ventricles, right? So it's going to hit, it's going to work around the AV node, right? Well, if you've got a VTAC, that's originating where? Down a little bit lower, right? So we're probably going to need an antidysrhythmic. All right, go old school, hit them up with some lidocaine, but nowadays it's probably going to be what? Amiodarone, right? Amiodarone. And then a wide complex tachycardia of uncertain type, which is more than likely going to be a monomorphic VTAC. So, again, I keep hitting on this, and I keep hitting on this, and I keep hitting on this, because that is going to be essential for you making a decision as to how to treat that patient. Are the symptoms being caused by the tachycardia? Or are they being caused by something else? Ebola. Yeah, sure. If they're being caused by the tachycardia, then I'm going to treat the tachycardia. That word. I'm going to have the tater tots. All right? If the symptoms are being caused by the tachycardia, we're going to treat the tachycardia. But if I've got a patient that just has a fast heart rate and he's got something else wrong with him, you know, we joked about Ebola, but infection. Infection causes lots of signs and symptoms that makes your heart rate go up, but if I treat that heart rate, if I hook somebody up and shock them, they're still going to be infected and they're still going to be sick, right? So, is it being caused by the tachycardia? If so, I'm treating the tachycardia. Now, I'm looking at the patient. Okay, the patient has got these signs and symptoms because of the tachycardia. Are they stable or unstable? So there's several key decisions that you have to make. Several critical thinking steps that you have to take in order to get to your appropriate treatment. So looking at stable versus unstable, we know that patients with unstable tachycardia, immediate treatment with what? Synchronized cardioversion. If it is a pulseless tachycardia, of course they're going to have unstable signs and symptoms, but we're not synchronized cardioverting them. We are defibrillating. Also on the street in gang talk known as unsynchronized cardioversion. Note the difference. Asynchronized or unsynchronized cardioversion is just defibrillation. Look for the two little letters in front of it. Stable tachycardia, then you got a lot more work to do because you got to give meds and start an IV and all that. You can't just shock the crap out of them and hope they get better. Oh, patience. So what do? Well, first you got to decide, is it a narrow complex or a wide complex? Because your treatment is going to vary. Is it a narrow complex SVT or AFib with RVR? Or is it a wide complex VTAC or polymorphic VTAC torsades? If it's a narrow complex, We're hooking them up with what? Adenosine. Rapid IV, right? 6 and 12. 6 and 12. Also, they may want to give them a beta blocker or a calcium channel blocker. Let's think a minute just back to pharmacology. If we've got something that is firing really fast, why would we want to give a beta blocker or a calcium channel blocker? Let's talk about the beta blocker first. What does the beta blocker do? It blocks the betas, like the little fish that swim around. The beta adrenergic receptor sites, which are part of what nervous system? The sympathetic nervous system. What does the sympathetic nervous system do to the heart? It says, yo dog, you need to speed up, hurry up, go, 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 right? Have y'all had this much energy in class all semester? It tells the heart, hey, we need to speed up, we need to go, go, go. Alright? So we give a beta blocker, and the beta blocker comes in and says, yo dog, slow down. It's going to block the stimulus from the beta adrenergic receptor sites. It's actually going to take over the adrenergic receptor sites. And so it's going to help slow the heart rate down. How would a calcium channel blocker work? So this is going to take a little bit more thinking.
Slow the refractory curve.
I hear you, dog. Is going to get into the cycle. Remember you've got your stage 0, stage 1, stage 2, your sodium potassium pump. You've got your sodium rushing in and your potassium going out. And then you got your calcium coming in, and the myocardial cell depends on that calcium to contract. So if we block that channel, it's going to slow down the influx of calcium. So it's going to block the rate of contraction in which the heart, the myocardial cells pump. So it's going to help slow it down a little bit. Y'all following me? I heard the word confused. Is somebody confused? Okay. And then, of course, get an expert. I'm that guy that stayed at the Holiday Inn last night. Well, it's got to be a Holiday Inn Express.
That makes him an expert?
Yeah. You never seen the commercials?
That's what I'm doing wrong.
Yeah, you're sleeping in your own bed at night. Do what? You don't have time to watch TV. Those commercials are old. They're probably older than a lot of y'all in here. So, your narrow complex, adenosine. Your stable wide complex, we can try adenosine. Probably need to do more than just consider an antidysrhythmic. Alright? Probably need to do an antidysrhythmic infusion. So, I think we've hit treatment pretty good. So you've got adenosine. You've got diltiazem, also known as cardizem. What type of medication is it? Oh, it's a calcium channel blocker. Calcium channel blocker. It is used in AFib. The beta blocker, the drug of choice for the American Heart Association tachycardia algorithm is sotalol. LOL, L-O-L, LOL, ha ha ha. LOL, sotalol. That's the beta blocker that's on there. But there are other beta blockers that will be used. You've got your metoprolol. You've got your low pressor. Alright? Atenolol. Things like that. Amiodarone. What is amiodarone? Antidysrhythmic. Your digoxin. Cardiac glycoside. That's what I'm talking about. I hurry up. Digoxin. Also known as lanoxin. Where do you see it commonly taken? What type of dysrhythmia do you see it commonly taken? Especially in old people. AFib. Alright?
That's the one you can get poison from,
Yep, it's got a very narrow therapeutic window. Verapamil. It is a calcium channel blocker. And then mag sulfate is going to be your drug of choice for what? Torsades polymorphic ventricular tachycardia.
You just shut it out right
I did. So, VTAC and VFib. We're going to get through these and then we're going to break for lunch when we get to the case studies. VTAC and VFib. So what do we know about VTAC and VFib? If we see it on the monitor, we're checking for what? Pulse. If we do not have a pulse, you call 911. You get the AED, right?
Activate the emergency response.
That's right, the chain of survival. The chain of survival, my friends, is what's going to save a life. Where do we fall in? We fall in starting CPR. I mean, we could fall in where the ALS shows up, but let's just back up. All right? So, the chain of survival. The number one thing that anybody in pulseless arrest, be it VTAC, VFib, assistedly, or PEA needs is, want to demonstrate for us, Ryan? Oh, come on. Ryan has patented, yeah, that word, the art of twerking CPR. You can twerk that time while you Who am I going to pick on next? All right. Anyways, CPR and early defibrillation, right? They need to be asynchronized cardioverted, right?
That's also known as fibrillation.
Also known as defibrillation. All right? And then, of course, you're going to run with your epinephrine or your vasopressin. And then lidocaine, which lidocaine only works on the ventricles. And just in a very elementary thought process, it numbs up the ventricles to where they're not really moving a whole lot. They slow them down. All right? Who's with me?
What are we doing?
Whatever.
Just making sure.
Whatever. I'm all in, brother.
I was just asking first. Last time I signed up for something.
You just hope the videos aren't circulating.
Yes,
So, assistedly and PEA. So we've got our braided, our too slow, our too fast, and then our not moving, which is going to be your VTAC, VFib without a pulse, or your assistedly PEA. Now, why is VTAC without a pulse not called PEA?
Because it's not sinus rhythm.
And PEA doesn't have to be a sinus rhythm.
Because it's a
Well, if you don't
shockable
have a
rhythm.
pulse, it's not.
Because it's a shockable rhythm.
It's pretty much because of what algorithm it falls under. Because if you want to, I mean, if you want to get all technical about it, it is. I mean, it's pulseless electrical activity. But you don't call VTAC without a pulse PEA. You call it VTAC without a pulse because it falls under a different algorithm. All right? It falls under an algorithm that other treatment will actually affect because it's a ventricular origination. Okay? All right. You ready for break for lunch, or y'all want to go for a little while longer?
Let's get it done.
I have to be here all day. Okay. 30 minutes. 12 o'clock, I'm taking a break. I got taco soup. I cannot miss it.
Lunch for this case study is 30 minutes.
Just like a student, all the time trying to get out of something. Jeez.
We're trying to learn.
Trying to learn, trying to learn.
Come back up here.
All right.
Be up here all day, so it don't matter to me.
Let's just go lunch now.
We gotta come back.
I vote we go to lunch now.
I vote we go to lunch now too.
He just said we got.
All right. So let's just work through these together, just so that we can hone back in on our skills. Some folks have bow staff skills and nunchuck skills. You guys are going to have your cardiology skills. So, we're going to give you the case study, give you the information. I want you to write out your treatment. I want you to write out your interpretation of the strip. I want you to write out what algorithm you're going to use. And then write out the treatment and, other assessment things that you may think you want. All right? Patient 1, 65-year-old female. She's complaining of sudden onset of shortness of breath and fluttering in her chest. Her initial assessment, she's alert and in mild respiratory distress, and her airway is clear. She was vacuuming the house when she suddenly became an SOB. When she became short of breath. She denies a history of heart disease, reports periods of palpitations in the past. So what now? All right.
Oxygen.
Okay. So we're going to jump in. We're going to assess. We're going to get ABCs, vital signs. Can y'all see to right?
No.
Yeah.
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 We're good.
Vitals, respiration 20, blood pressure 110/90. She's 93% on room air. Monitor reveals what you see above. All right. So I want everybody to work it out real quick. I'll give you 3 or 4 minutes to work it out. And then we're going to do it together. All right. Still working it? All right. What's your rate?
180. I got 150 with the R.
150 with the R to R. So 2 big blocks. So if you do your 6-second method here, it's going to be
160 with 6.
yep. 160, so 150, 160. Regular? CP wave? What about a PRI? Can't really do one, can you? What about your QRS? All right, narrow, upright. What's its time?
I can't really tell with it.
Looks like you got, yeah. Yeah, it's kind of hard to see up there. It's less than 0.10. All right. So what is it? SVT. What makes it SVT and not paroxysmal SVT? Because you didn't witness it. If you would witness it, if you saw it going from one to another, it would be paroxysmal. All right? So, is she stable or unstable?
Stable.
Hemodynamically, blood pressure was 110. Just talking. So, yeah. So, what algorithm? Tachy with the pulse. But we're also going to have to identify stable, narrow, complex, regular, because there's a couple of tachycardias in there you have to identify. All right? So, number 1, do you think her signs and symptoms are coming from the tachycardia? Yes. Number 2, she's stable?
Yes.
Number 3, narrow or wide complex?
Narrow.
Narrow complex. Stable, narrow complex. First, what's your treatment? All right, 12 lead, but all right.
12 lead oxygen, IV, vagal therapy.
Yes.
If vagal doesn't work, then
All right. So is the tachyarrhythmia causing hypotension, altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure?
No.
No. Is the QRS wide and greater than 0.12?
no.
No. Start IV. Obtain 12 lead. Vagal maneuvers. Adenosine, if it's a regular rate, remember, where they may throw in a beta blocker, calcium channel blocker, and then you got to get somebody that knows what they're doing. All right. Any questions about that?
No.
All right. I'm going to tell you guys, I'm not rushing through this whether y'all are ready to go or not, so we're going to take time with it.
He looks so confused that nobody else was not there.
I am confused. You would think that after a year in school and realize that we don't really like for you to be late. Well, you're fine. You have an excuse. Patient 2, 58-year-old male, found down, DFO'd.
Like what?
He fell out. He done fell out. He done fell out. He done fell out. Initial assessment. Nobody can confirm how long he's been down. CPR was started by a first responder. You have them stop CPR, and you feel no pulse, and the plot thickens.
So we start CPR.
Okay, what do you do, though, before you start CPR?
I'm on the monitor.
Okay, even before that, what did somebody say? Check a pulse. I've been on a scene before where people were doing CPR on a pulse. So you should probably confirm and know that bystanders are good Samaritan, helpful people, but may not always be able to do an assessment like you can. Okay?
Or all the
Resume CPR. He didn't have a pulse. Apply the monitor. What next?
We would establish an
There's your monitor. Don't give it away.
Sorry. That's a great one.
All right. Rate. Does it really matter?
No.
Rhythm. Doesn't matter.
No.
P, PRI, QRS.
No.
No, not really. Not at all.
Great.
However,
He has a pulse.
you reconfirm that the patient does not have a pulse with this rhythm. So what's the rhythm? Because somebody y'all threw away my suspense there. PEA, pulseless electrical
Activity.
yeah, that word. Activity. It used to be called electromechanical dysfunction. How could that, why does that make sense that it's called
Because
electro?
it's not causing mechanical.
Because, or not dysfunction, disassociation. Because it ain't working together. The electrical and the mechanical ain't working together, right? If I had a patient that had this rhythm right here, they're probably okay, right? If they had a pulse and all that, right? So that ain't a bad rhythm. But what makes it bad Is it when the heart ain't pumping? It don't matter. So what algorithm? PEA, asystole. What's the complete name? Cardiac arrest, asystole / PEA. Continue. High quality CPR, the chain of survival. You know, in all honesty, we are paramedics, but it really doesn't matter if we can drop that ET tube in like a champ, if we can start an IV perfectly and give all the epinephrine and amiodarone and everything else. If we're not pumping that heart, if that heart ain't circulating that medication around, it does not matter. So do not forget your basics. The most important part of a cardiac arrest is not what you can do as a paramedic. It is what the Joe Blow bystander can do in the field. All right? Now, what you do as paramedics is going to further help the patient if they have high quality CPR and they are defibrillated quickly. I'm telling you this because the word's been out on registry that there's a lot of questions that send you back to your basics. You always hear, never forget where you came from. If you forget the basics, that patient will die. And it happens. I can't tell you how many cardiac arrests that I've worked where you get so caught up in doing an IV and drawing up meds and dropping an ET tube in that time's gone by and it's been a minute since anybody's pumped on the chest. Has everybody in here worked the code at this point? Do you know what I'm talking about? So the best thing that you can do as the team leader, as the person responsible for that patient, no matter what you're doing, drawing up, give all my answers away. No matter what you're doing, you, as the paramedic, need to make sure that someone is doing CPR. And not just somebody needs to start CPR. Sam, do CPR. Kayla, Swapple Sam, start CPR. Do that. Because if you can get them to the hospital and good compressions have been going on, they've got a much higher chance. What was the statistic, Anthony, on just compression-only CPR?
It was like 14% of the bystanders in before that it was, the traditional was at 7% survival rate. So they went up, it doubled.
So a much higher survival rate with just CPR. So everything else we can do just adds to it, but CPR is, compressions is your most important. So how long? We're working now, we're in the algorithm. How long do we do that?
2 minutes.
2 minutes. Ventilations. So, what's our priority with ventilations? Just making sure air is getting down one way or another, right? It doesn't necessarily always have to be an ET tube, right?
Don't overventilate.
And don't overventilate. If we can be sure that we can put an OPA in and that we can make sure that we've got good chest rise and fall, if we never get to dropping that ET tube in, we're still doing the patient good. Okay? So, an IV started, an ET tube is placed, you've got tons of paramedics with you, breath sounds are noted. What's the first medication in this algorithm? Epi. Well, oxygen. Yeah. Way to go, Hillary.
Good job.
You know, I'm just going to recommend you to go ahead and get your license. You don't need to take registry.
Cheaper that way too.
Yeah. All right. So epinephrine is your second drug next to oxygen. Epinephrine, what's your dose?
1 milligram.
Of what solution? 1 to 10. What if you didn't have an IV?
1 IO.
All right, IO. You've already got an ET tube placed.
Double it.
Drop it down the ET tube. All right. IO is your next option. You've got different options. Down the ET tube. So fluids are going. Why do we want fluids going with that IV? Circulating. Now, that's going to be all right as long as what? We're doing compressions, right? Or the heart picks back up. But if we're just dumping fluids in to a pump that's not pumping, it's just going to build up, right? History reveals that the patient's a chronic alcoholic and that he's been sick for the last few days. He's been vomiting blood and has black starry stool. He's a tool too. His abdomen is distended and rigid. What other treatments, what other medications, what other things would you consider as part of your H's and T's?
Sodium bicarb.
Okay? Thiamine. Usually you're not going to push, well, what's your dose of thiamine? 100 milligrams. Sodium bicarb. Why are we thinking sodium bicarb? Yeah. Patient's acidotic, so we might want to try to neutralize out a little bit. What's your dose? All right. What is an amp? All right. All right. So 1 milliequivalent per kilogram. Usually an amp is 50 milliequivalents. So like an amp of D50, an amp of sodium bicarb. Then your D50, what is it? Dose? 25 grams IV. What would you consider for treatment if the patient had a chest injury? We're just kind of thinking outside the box now. What if you were working on this patient and he... Alright, so we're definitely trying to make sure that he's expanding and all that. We might be thinking pneumothorax, hemothorax, or something like that, so they might need to be maybe looking towards decompression. What if he had cardiac tamponade? What if it was an issue from cardiac tamponade? What are we going to do in the field for that? Yeah, he's going to need a pericardial centesis, right? We're not going to. What? No matter what TV show you watch.
You don't do that?
Some.
It's in our book.
I mean, I do, but y'all don't. I mean, you got to have skills, dude. Yeah? Alright. Would there be any changes if that rhythm was a bradycardic rhythm? Nope. No. Alright. Nope. Case 3. 68-year-old female patient was found unresponsive on the floor. Is now awake but not communicating. I sure ain't going to open the door with them knocking on it.
Don't let them in.
You said you weren't going to do it.
Told y'all not to go to nippers. 68-year-old female patient was found unresponsive on the floor. All right, we got to get back into this. Is now awake but not communicating. Husband states she has an irregular heart rate and takes medicine for it. She's conscious and only responds to commands. And she's displaying expressive aphasia. Expressive aphasia, what is that?
Understand.
She's having an issue of trying to get her words out for you to understand. What now? Well, this is cardiology, so what are we going to do?
We put her on some oxygen.
Throw her on the monitor.
So she is
Her pulse.
AFib.
Irregular. Y'all work through it. Work through it. Respiratory rate is 32. Blood pressure is 212 over 122. All right. Rate. What's our rate? Well, if
All right, is
we don't really have a matchup of P and Q, so it's variable, right? As you will see with any irregular rhythm. All right, P wave. Can you see one? Normal or absent. There's some that are kind of fibrillating, so obviously you can't really get a PRI. QRS. Yeah, it's pretty regular. So what's the strip? AFib. What do you think's going on with this patient? Found on the floor, unresponsive, expressive aphasia. She's stroking. That's what she be doing. She's stroking.
Her blood pressure was down.
Would you say, Kane? Ischemic or hemorrhagic, would you suspect? Ischemic. Her blood pressure is really, really high, but considering that she has a history of AFib, there's a couple of things that you might need to ask.
Is she on
Any
any
medication?
All right, is she on any medication? What what medication might she be on to control rhythm? Dig, right? What about what kind of medication would she be on because of the effects of AFib? What? Coumadin or warfarin, right? Why? Why would somebody be on an anticoagulant if they're in AFib? All right. So in AFib, you've got a good ventricle contraction, right? But you don't have a good atrial contraction. And you don't have a good kick. But what's happening to that blood? Yeah, it's stagnating, right? It's pulling, and high probability for it to form a thrombus. That thrombus could break off. Boom, bam, you've got it. So is she stable or unstable at this time?
unstable?
Unstable. What algorithm would you use? You would use the unstable and the stroke protocol. However, with the tachycardia, there's a couple things that you're going to have to look at as far as AFib goes. Number one, you probably need to call med control on this, because he may not want you to convert this rhythm. Why is that?
Because they have a chance
So
of going in.
more clots happening.
Right. If you convert this rhythm and now the atria is pumping normally, what's it going to do to any other thrombus that's formed in there? It's going to push it on through. All right? But the reason why I'm throwing this in here is because I need you guys to understand that AFib, especially a fast AFib like we saw, is going to fall under your tachycardia algorithm. All right? It would be considered narrow. All right? Now, I think I told y'all the story about the time I was working in LaGrange, but I'm going to tell it again. We had a lady that that was in SVT. I thought she was in SVT. Called the doctor, and the doctor told me to try adenosine. All right. So she was a stable SVT or whatever. She was talking to me, hemodynamically stable and all that. But he said try adenosine. But from what you're describing to me, it's probably going to be AFib RVR. He said the way that you can tell in the field quickly is give adenosine. If it just flutters down and then goes right back up, it's probably going to be AFib RVR. Now here's the deal about AFib RVR is that we were talking earlier about it being irregular and all that. If it gets super fast, you're not going to be able to tell. Alright? But I gave adenosine and fluttered down. I tried another dose of adenosine and fluttered down and went back up. And he told me on the phone, by the time you, or if you give those, if that don't work, you need to try, what do you think? We didn't have Cardizem on the ambulance. Amiodarone. Amiodarone. Well, we got to the hospital before I had time to pull the amiodarone up. We get into the hospital and they give the amiodarone and it flutters down and it slows it down. They give another dose and they slow it down. Then they give them some Cardizem and it further slowed it down. Alright? So, that being said, adenosine's really only going to work on a supraventricular tachycardia, not an AFib RVR, because it affects, adenosine affects the electrical conduction of the AV node. Okay.
How would you know it was AFib RVR and not SVT?
Well, I didn't, but I knew that when I gave adenosine, if it was a SVT, I'm expecting it to do what? Flatline, and then maybe come back and slow down some. Well, when I gave it, it fluttered down to like a rate of 90, but then it went right back up. And so, really the only way to really do that is going to be to get a 12 lead and be able to really interpret it, and didn't have time for all that. Alright? Nobody. Alright? And so your suspected stroke protocol, don't want to get a whole lot into this other than the fact that you do need to make notice that if it's AFib and you've got all these other signs and symptoms that's leading up to this, there's a few things that you need to do, especially if you're working in Alabama. What's one of them? Call the stroke center. Alright? But you're also going to need to try to figure out downtime. You're also going to need to do a thrombolytic checklist. And this is going to need to be done quickly. And this information is going to need to be relayed to the stroke center. And then it's also going to need to be relayed when you get to the ER, because, especially in this situation, they're probably going to be a candidate for what? TPA, if they meet all the criteria, right? Case 4. 70-year-old male. Altered mental status. Weak. You find a 70-year-old male who is confused. He's weak and dizzy when he stands, and the patient weighs 160 pounds. The patient was watching TV and stood up and became weak and dizzy. This has continued, and he is becoming more confused. He's had heart trouble but does not take any medications. What now? The pulse should say regular. Respiratory rate is 32. The blood pressure is not right either. I forgot to change that. His blood pressure is going to be like 80 over 40. So what's your rate? 40 using the 6 second? What's your rhythm? What's your P wave? You got one? What's your PRI? Got about 0.2. What do y'all got? I want y'all to be working with me on this. Alright? And your QRS? present in about 8.8 seconds. Is that right? Yep, 2 boxes. All right. What is it? See, stable or unstable? Unstable. Blood pressure 80/40. Having difficulty breathing. So, what algorithm? Symptomatic bradycardia with a pulse. Oxygen.
Cardiac monitor.
Monitor. I don't know what happened there. All right. Consider atropine. Go ahead and give it. But you know that you're going to have to do what here? You're probably going to have to pace. You're probably going to want to go ahead and hang a dopamine drip on this situation because he is hemodynamically compromised to a pretty good point, all right? So if we give dopamine, and I'm almost willing to bet dollar for dollar that you're going to have to figure out the dopamine drip. I'm telling you guys, don't use the stuff that they tell you in the field right now, the quick reference, take the patient's weight and subtract or whatever, or take whatever. Don't do that. Know how to do this so you get it right.
I don't have a calculator either.
Do what?
You don't have a calculator either.
You don't have a calculator in the field.
Yeah, you do.
Okay, you got one on your phone. There you go. You don't have a lot of time, but I'm telling you guys, know how to do this. Most of your dopamine is going to be in a 1600 microgram solution. 8 milligram in 500 milliliter. Alright? So, dopamine is a weight-based calculation, right? Starting at about 5, the first step. Are y'all paying attention here? Your first step, you're going to multiply your 5 mics times your 75 kilograms. So that's going to give you 375 mics per minute. All right? So now, the first thing you're going to have to do, or the next thing you're going to have to do, is just do basic drug math. But you're going to have to convert micrograms to milligrams, or milligrams to micrograms. You follow me? I see some of y'all asleep. So using your formula, just the regular formula, your desired dose is 375 mics. How do we get that? We multiply 5 mics, because that's going to be our initial starting dose of 5 mics per kilogram, times 75, which is our kilograms, right? So 375 mics per minute. So our desired dose is 375 mics. What is our volume? Our volume is 500. Our package is in 500 milliliters. Now, I work better with big numbers than I do with decimals. So when I do things, I always convert my milligrams to micrograms. So 375 times 500 gives you 187,500. Divide that by your 800,000 mics. All right? Everybody got, see where I got 800,000? Because I converted my 800 milligrams. All right? So that gives you 0.23 milliliters. That's just giving you how much you're going to give from out of your package. So then you've got to figure out your drip rate. What's the problem, Hillary?
I was just asking how we're supposed to do this on a test for registry.
How?
In her head.
Yeah. I mean, I can't do this in my head.
You don't have a calculator.
No.
You don't have to.
You got
There's a pop-up when you get on the screen.
Yeah.
No, that's what that CV then
Well, I'm just telling you, you can guess, you can do whatever, but I'm just telling you, if you're going to move forward, you've got to know how to do weight-based formulas.
I mean, I know how to do what I say and I would get back there.
So now we need to figure out our milliliters per minute. So 0.23 times 60 minutes gives you 13.8 milliliters per hour. So if we were doing a drip rate, it would say the physician has ordered you to give 13.8 milliliters per hour. What is your drip rate? So you multiply it times your 60 drip set, divide it by your time in minutes, which is 60, which gives you 13.8. All right? So your drip rate will be around 14. Now, you can use your little chart in your protocols. In Alabama protocols, there's the dopamine thing, right? So yeah, there's not going to be a huge difference in 15 and 14 drips per minute. All right? However, if you're testing and you need to get an exact number, you're going to need to know. Okay? So his weight was what? 75? So in between 70 and 80, so it lines up at 5 mics and says it's 15 according to this chart here. We got 14. So it's close. All right? All right, so for the next couple slides, we're just going to practice interpretation. I want everybody participating. If you think that you're above doing this and don't want to participate, then you might as well just go on and go now because I'm not directing towards you. All right. So what's our rate here? You got a rate of 70? Oh, there's your answer. I was trying to write on it. Rate of 70. Is your rhythm regular or irregular?
Regular.
You got a P wave? What's your PRI? What is your PRI? Somebody tell me. What did you say? I got 1, 2, 3, 4, 5. About 5.5. We'll just go with 6 blocks there. So 0.24. QRS. So, it's not upright, it's inverted, right? We got about, I'd say that's more of about a 0.6, wouldn't you? Look at it, you got one full block and then a half a block where it meets. Alright, so it's first degree AV block. What makes it first degree AV block? Yep. What's your rate? You're going to have 2 rates on this. Alright? So around 70 for atrial, around 50.
I think it's more like for atrial. Probably 120 for atrial.
You're right.
I said 2, 4, 3, 6. Yeah, I'd say 100.
Alright. Atrial around 100. Ventricular. You're going to count this as a whole.
Yeah.
One. It's hard to see these. Can't see it up here. So there's my start. Y'all can't see it. There's my start. So there's a 3 second. And there's a 3 second. You can't see it real good.
About 61.
For ventricular.
So 35, 40.
Alright. 1, 2, 3, 4, 5, 6. So we're looking at about a 60 atrial rate and probably I wouldn't. This complex right here is not in your 6 second strip. It's right here and right here. So I would probably say 25 to 30. Crap!
I mean, we knew it.
Alright. Your rhythm. Irregular? P wave, they there? Is there a P wave for every QRS? No. PRI? You can, yeah, it's not one. And then you do have a QRS complex. And it's wide and bizarre.
Wide and bizarre.
So that's a third degree AV block. Disassociation between your P wave and your QRS.
Wow.
Alright.
Yes. That was all easy. I hope you're a torso.
You look at each 5 big block section is 1 second.
I'm so sick of sneezing.
Yep. This is a 6 second strip. So what's your rate? 70. Alright, so your rate is around 70 ventricular. Rhythm, regular or irregular? Alright. What about your P wave?
It's there.
Rounded in the upright.
Okay? So you do see a P wave.
The RI varies.
Alright. So what is it?
I was agreeing.
It's type 1.
It's getting lower and lower.
Look at your P wave. It's close. They're arguing, so they're getting their distance. They're arguing again. They're getting their distance. They're getting their distance. Finally, the P waves just had it. QRS drops off. They come back together. They're getting their distance. They drop off. There. And so it actually may be going into either a third degree or if we have more of a strip, we might even see it as a second degree type 2 at this point.
That's what I was
But you're looking at your first part of it.
What do you think they're doing when they drop off and nobody can see?
Probably going to visit the kidney.
Yeah. Could be one thing they would do.
Mobitz 1 or Wiki Bop. All right, rate.
Sorry, please.
Fast. Really, you could say about 180 because it is a complete cure, or it's a complete ventricular complex, even though it's not a normal rhythm. Is it regular?
No.
Yeah, it is. It's regular. You're just checking, weren't you?
Yeah, just making sure everybody's on.
That's it. Any P wave?
No. No.
So no PRI, QRS would be called what?
Wow.
Wide and bizarre. VTAC. Easy. Easy to identify.
Ryan.
Yes.
What about this fat cat right here?
I don't know what that Ron meant.
Besides, they'll put it.
Read about bag.
One day, if I'm gonna do this, I'm gonna say that. I'm gonna be like, you're gonna die. You're gonna have 4 sides.
All right.
Magnesium.
Rates not really discernible. Rhythm irregular. No P wave, no PRI, QRS. Bizarre, right? What differentiates this than seeing coarse V-fib? All right, you see it kind of twisting, torsades twisting at the point, but it's organized, right?
Yeah.
It's not organized like you'd like it, but there is some organization to that, okay? If this was coarse V-fib, it's just going to be whatever it looked like. You're not going to see something that looks like the same thing, okay? What's your treatment for this? Mag. All right. What's your rate?
60. He's right.
Are you looking at your 6 second, or are you just looking at the strip?
No.
1, 2, 3. 1, 2, 3. I'm going with 60.
That's what I went with. It's a wise choice.
It's 60. That's almost a complete one right there. If you were actually looking at the actual one, it's not going to be 60 exactly. It'll probably be like 58, 59, something like that. All right? Is it regular?
Yes,
You
it is.
see a P wave?
I do.
What about it?
Inverted.
It's inverted. What about your PRI?
It's consistent.
It's about 4 blocks, so about 2, 0. What about QRS?
Regular.
All right. What is this?
Accelerated junction.
Accelerated junctional. Why is it accelerated junctional? It's got a higher rate. All right.
This makes me feel like I've learned something in this paramedic school.
Case 5. 54-year-old male executive at an insurance company complaining of chest tightness radiating to his left arm for the past 2.5 hours. He's also complaining of slight shortness of breath, no previous history, but does have a remarkable family history of cardiovascular disease. Skin's pale, cool, and moist. Blood pressure 104/82, pulse 102, and regular. Respirations 20, good tidal volume. Pulse loss is 99%, and his lungs are clear. Chest pain's getting worse.
I don't know why.
Monitor reveals this. So, if we were treating this patient, the first thing we're going to do is throw on a 2 lead, right? If we look in lead 2 and this is what we see, we're throwing 12 lead on. But even more than that, the fact of what he's complaining of, his chief complaint, still going to get us to put a 12 lead on him. Did you say something else? Oh. All right. So, to interpret this, first thing, let's look at lead 2. And in lead 2, rate 75, rhythms regular, P-wave upright round, regular, PRI is a little bit elongated, QRS complex is present. So, if we were just going by those rules, not a whole lot to it, right? But we see something that's just jumping out at us that we've got to look at a little bit better. So with your 12 lead, you need to look at the individual leads and see what you notice. You have ST elevation in leads 2, 3, and AVF. All right? So, you've got ST elevation and concurrent leads that are looking at the same area. There you go. You all remember this one? Yeah. Inferior MI, because it's the easiest to look at. So, what do you consider as a possible diagnosis? All right, but more than that, just STEMI, right?
Yeah.
What algorithm will you use here? STEMI algorithm? There's no such thing as a STEMI algorithm. ACS chest pain. All right, y'all get your head in the game here. I know that it's getting late. Not really. You still have 2 hours in this class. Get your head in the game and don't just throw stuff out. Algorithm you'll use is your ACS chest pain algorithm. Now, that algorithm is a big algorithm because American Heart Association not only targets pre-hospital, but it targets in the hospital too, right? So we've got to figure out what our role is in that. So your initial pre-hospital care, O2, Mona Lisa, EMS assessment and care, monitor, ABCs, CPR, aspirin, oxygen, nitro, and morphine. What's my rule on nitro? Alright, that's not my rule. That's just the rule. But what do I tell you about nitro? What do you need to try to have before you get it? An IV. Everybody reacts differently, and especially if you're on that borderline, alright? Because this patient's borderline hypotensive, but still within the parameters to give nitro. Obtain 12 lead. ST elevation. Notify the receiving hospital. And transmit. Very important to note your time of onset. You've got to get that OPQRST in that sample. Alright? Why? Well, our treatment's not really going to... Alright? So they'll know what kind of treatment? So, exactly. So they'll know if this patient's a candidate for thrombolytic. So just like with stroke, you've got a thrombolytic check sheet that you need to do. Remember, with the heart, time is of the essence, but muscle. Time is muscle. Time is muscle. So, the more time that you can take out of the process in the ER and do in the field while you're transporting that patient, the less time it's going to take to get them to definitive treatment there. All right? Remember, with MI, you do not have to have STEMI to still be having an MI. You've got non-STEMI, and you've also got Q-wave MI stuff. We're talking about Q-wave abnormalities, but you may have a patient that just has a regular old rhythm, and if they're complaining of chest pain, and if they're complaining of all the things that's typical of MI, you need to treat appropriately. All right? Administer 1/325 or 4/81. Start an IV. Spray nitro. What's your dose of nitro? 0.4 sublingual. 2 to 4, going on 4. Now, let's talk about morphine for just a second. We're giving morphine because it's going to help do what with the heart? It's going to help reduce the workload. All right. So of course we're giving morphine to help with the pain, but more importantly than that, it's helping reduce the cardiac workload of the heart and the oxygen demand of the heart. All right. So one thing that I've noticed about when we're doing static and on these MIs, you know, you're saying, all right, I'm going to check a pain level, and if appropriate, I'm going to give morphine. Well, morphine is part of this protocol. If it's hurting them enough to where they're having chest pain to have nitro and aspirin and all that, morphine is just part of your treatment, all right? So never ever withhold treatment. Never ever withhold morphine of a patient unless, of course, they're allergic or they're very hypotensive or things like that, because it's got physiological effects of the heart as well as the pain relief effects, okay? So his chest pain is slightly better. If it hadn't gotten better, what would you have done after you've given your first rounds of medication? All right, you can repeat nitro, depending on the pressure. So of course you want to recheck the pressure. What about, yep, morphine. I think your max dose is what? 10. Now of course you start giving a ton of morphine, you're going to have to get in touch with the doctor. Now, in the field, morphine is, like I said, part of your chest pain protocol. So it is a medication that you would give just like nitro or aspirin. So you don't have to call to give morphine in the field if it's appropriate. Okay? So what other treatment would the patient need in the emergency department? That's it. This patient, we need to identify, especially in this, what? Door to balloon time. Remember we talked about that back in the spring. But this patient, more than anything, at this point, if he's got textbook STEMI, he needs to bypass that ER and have a cardiologist waiting on him in the cath lab. All right? So your 12 lead. Let's back up just a minute. What made this an inferior MI? All right, so it's in the inferior leads, which is going to be leads 2, 3, and AVF, right? So with your 12 lead, we're looking at other aspects of the heart, right? So we've got our limb leads, right? Left arm, right arm. So our leads 1, 2, and 3. But then we're going to put our chest leads on our precordial leads. All right, so 1, 2, 3, 4, 5, 6. Now, where is it primarily looking in the heart? We're really looking at just left-sided stuff. All right, we're looking at anterior wall, septal, all right, intraventricular septum, and lateral. All right, and then of course inferior, like we talked about. But there is a way to look at the right side. Do y'all remember how we do that? All you do is take lead 4, put it in the exact same place on the opposite side of the chest. When you run that, you're going to have to put AV or lead V4R. Yeah, that's it. You're going to have to put that because now we're taking a look on the right side as opposed to the left side. All right? They all come back to the one focal point here. Your negative is going to be here, and your positive, so V1 is taking a look here, 2, 3, 4, and so on and so forth. So you imagine a camera here taking a picture. All right? On your layout, now, I don't think that they're going to get real in depth with 12 lead, but they may very well ask you some simple stuff like inferior MI or anterior septal MI, you know, that kind of stuff, all right? They may even throw in some bundle branch block stuff or left ventricular hypertrophy stuff. And we're going to look at that real quick in here in just a minute. But what I'm saying is that in paramedic school is where you get the foundation for 12 lead, interpreting MI and things like that. You're not expected to be just a proficient expert at 12 lead at this point, but there is a very real possibility of 12 lead questions being on National Register, okay? So leads 1, AVL, V5, and V6 is your lateral. Makes sense. V5 and V6 is on the lateral portion, right? So we'll be looking on the wall, the outside wall, all right? 2, 3, and AVF is your inferior. And then V1 and V2 is septal, all right? V1, V2, so they're looking down the interventricular septum. Then V3 and V4 is anterior. And it's set up just like that on your 12 lead. All right? So this would be an anterior-septal AMI. Where do you notice the elevation at? All right, V1, V2, V3, and V4. V1, V2, septal, V3, V4, anterior. All right? Does that make sense on how it flows? Well, your bundle branch blocks. Remember, with a bundle branch block, your electrical activity has already made it through, your conduction has already made it through the AV node, and now it's hitting the bundle branches. So if you've got a left bundle branch block, then it's going to block ventricular contraction on the left side. If you've got a right bundle branch block, it's going to block ventricular contraction on the right side. Now here's the thing about the heart that I wanted to throw in. The heart has these aberrant pathways and re-entry pathways, which goes into the characteristics of a myocardial cell, that all the cells can conduct and all the cells can contract, right? So if the electrical, if the stimulus has made it through the AV, and now we're at the bundle branches, all right, and it's going good on this side, and then we have a left-sided one. If it hits that block right there, what's going to happen? The electrical current's going to try to come out and go around, right? So it's going to find a different pathway and then try to come back in, all right? That's one of the properties of that. So that's where you get your aberrant pathways and your re-entry. When you're looking at it on a 12 lead, it's done by determination of the QRS width. If it's wider than 120 milliseconds and originating in the SA node, if so, there's a bundle branch block present. You always hear, just look for the rabbit ears, but they're not necessarily the most reliable thing. The 12 lead, especially in V1, is going to be your best place to see. All right? So this is a left bundle branch. Do you see the QRS? It's very different than what it should look like, and it's down. All right? So think of your turn signal. Here's my steering wheel. Here's my turn signal. If I push my turn signal up, it's going to be, we're turning to the right, right? If I push my turn signal down, we're turning to the left. What do you notice about the QRS here? It's down, right? Go to lead V1, identify the J point. Which way does the QRS complex go from the J point? If it's down, it's a left. If it's up, it's probably right. All right. Now, you see it's pointing up here in V1, so we're looking at a right. Now, what do you notice about it here in V2? It does have the rabbit ears, right? So essentially what you have here is two entirely different complexes. The left and right bundle branches are not in sync together, all right? So what you see is a QRS for the right bundle branch, or a R wave for the right bundle branch, and an R wave for the left bundle branch. Does that make sense? So when I've got it going down on this side and a block here and it comes back in, so I'm going to have, in my complex, I'm going to have a Q wave here and a Q wave here. They're just going to be closer together. So that's where the bunny ears come from. Okay? With your A flutter, I just threw these in. With your A flutter, you've got to look at your flutter waves and look at your conduction. All right? This is a 4 to 1.
Where does that fall in?
Tacky, if it's systematic.
Is that a 4?
That's a 3 to 1.
That's what I put. Actually, no, they're counting flutter, 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 flutter wave.
And you count the down spikes, not the up spikes?
The bass drum is a QRS. And then this is your atrial fibrillation. Rick James. All right, here's your winky bot. Listen,
Clearly, Doc.
the snare is the P wave and the bass is a QRS. All right. And so, lastly, your adult immediate post-cardiac arrest, ROSC. What are some of the things that we're looking for that's going to determine therapeutic hypothermia? All right. Was it a witnessed arrest? Was it a witnessed arrest that involved a shockable rhythm, and did we shock? And then did we have return spontaneous circulation? All right. If they're still unresponsive, but we have return of spontaneous circulation and all the above met, what's our role in EMS for this? Identify, start packing them down, let the ER know to have the Arctic Sun machine ready to go. Did they ever do one when you were teching in CV? You? That's right, because we were the best. I had several. Whenever we first started it, we had several test runs of it. But I don't know, I haven't kept up with it recently, but I know for a fact that they've had 2 or 3 that have walked out because of it. And basically the therapeutic hypothermia is going to be to slow down metabolism to help preserve neurofunction, right? But getting back to the return of spontaneous circulation, if a person is been in cardiac arrest and you get them back, you get a pulse back, they're probably going to be in cardiogenic shock, right? Because the pump hasn't been working. Unless you've been doing some big time CPR and doing it really, really well, all right? If you're twerking that CPR and working it, you're good, right? That's it. For us in the field, especially if it's a longer transport time, it says consider vasopressor infusion. We've only got really 2. We've got epi and dopamine. Dopamine's going to be your easiest one to hook up, all right? So in this situation, we're giving dopamine. Number 1, it is going to help with rate, but we're giving it for its inotropic agents. or its properties, and we're giving it because it's got vasopressor qualities. So it's going to help kind of push the blood back. All right? Any questions about that? All right, last couple of review questions. What is pulseless electrical activity? All right, so electrical. All right.
Disassociation with the electrical and the mechanical part of the heart.
There you go.
Isn't that what you said?
That's it. So PEA refers to an organized cardiac rhythm other than ventricular tachycardia on the monitor that is not accompanied by a detectable pulse. What's the difference between PEA and asystole? So asystole is the absence of any electrical activity, right? PEA, you've got organized electrical activity, it's just not making the myocardial cells contract. What's your treatment for both? CPR, epivasopressin, your cardiac arrest, PEA, asystole algorithm. Somebody tell me unsynchronized cardioversion.
Is not required on the ROA.
Okay.
Any time in the complex.
All right. So what's another name for unsynchronized cardioversion? Defibrillation or asynchronized. Unsynchronized cardioversion is defibrillation, which is an intervention used to interrupt rapid chaotic rhythms by simultaneously depolarizing all cardiac tissue in hopes of allowing the SA node to resume the function of the primary pacemaker. It's not a jump start. We're not jump starting the heart. We're actually sending electrical current through the heart to make every single myocardial cell depolarize at the same time.
And start up again at the same time.
And to start up again at the same time. But not all of them are going to start up at the same time. Right? We're hoping that it gets back on a normalized electrical pathway. So, somebody explain synchronized cardioversion.
Fire on the R wave.
Alright, fires on the R wave. It interrupts rapid, organized, and hemodynamically unstable rhythms. Synchronized to deliver energy precisely at the peak of the R wave to capitalize on the already depolarized state of the ventricles. What's your electrical dose for synchronized cardioversion? 50 to 100? Alright, so I'm having a bunch of numbers. I'm not saying y'all are wrong. You've got to identify what type of rhythm it is. Narrow regulars, 50 to 100. Narrow irregular, 120 to 200. And then wide regular is 100. If it's a wide irregular, defibrillation. Alright? Heads up, we're almost done.
This is your question.
What is the absolute refractory period?
That is the rapid influx into the heart.
The absolute refractory period. Period of time that no outside force can act on. Alright. It's the early phase of cardiac repolarization. The heart muscle cannot be stimulated to repolarize. Alright, so no outside force can act on it. You've got the relative refractory period. The relative refractory period is the late stage of cardiac repolarization, but it can receive a stimulus. What happens if you have that happen? What's that phenomenon called? R on T. So the ventricle has not completely repolarized yet. It hasn't completely rested. But now the heart is starting to contract again. So the ventricle is starting to contract again while it's still trying to relax. Alright? Remember, I think Ms. Curry explained this to you guys. It's like a toilet, when you flush a toilet. Y'all remember that? When you flush a toilet, initially, you can't flush again, right? You can't jiggle the handle. That would be the absolute refractory period. But as that bowl starts filling up, as it gets back to almost where it needs to be, you can then act on it and flush the toilet again, right? What are your limb leads?
1, 2, AVF, and AVR.
1, 2, 3, AVR, AVL, and AVF. What are your precordial leads? V1 through V6. Your precordial leads in AVR, AVL, and AVF are what you're going to see on a 12 lead. However, you can run an AVR, AVL, or AVF if you've just got your 4 leads on, and it all has to do with the polarity of your leads. Which leads make up Einthoven's triangle? Leads 1, 2, 3. On Einthoven's triangle, in lead 2, where is the negative pole? Right shoulder. So your positive is where? Left leg. Inotropy or inotropic. Alright? So it's the strength of the contraction, the contractile force of the heart. So an inotropic agent, such as dobutamine, and even some of dopamine, is going to affect the contractile force of the heart. Here's the problem with the inotropic agent, though. If it's going to increase the contractile force of the heart, it's also going to increase the workload of the heart, right? So you have to be real careful with that. What is chronotropy? The rate. The rate and movement of the heart. So a positive chronotropic agent is going to do what? Increase the heart rate. And then dromotropy, or dromotropic. So it has to do with electrical conduction, an agent that influences the conduction of electrical impulses. So a positive dromotropic agent enhances the conduction of electrical impulses in the heart. So it's going to speed up conduction. Adenosine, I think. Yeah, atropine. So it's going to help speed up the conduction of the heart. All right? Somebody had asked me to explain inotropy, chronotropy, and dromotropy. So there that is. All right? So atropine. My answers just popped up. Atropine. Atropine is a parasympathetic blocker, or a parasympatholytic, all right, or an anticholinergic. All three of those words refer to blocking the effects of the parasympathetic nervous system. Cholinergic effects are the effects of acetylcholine, which is the parasympathetic chemical mediator. So atropine, it opposes the vagus nerve used to speed the heart when excessive vagal firing has caused bradycardia. The vagal nerve is a nerve of the parasympathetic nervous system. So if it's stimulated, it's going to act on the SA node and it's going to slow the heart down. So we give atropine to block those effects of the vagal nerve and to speed the heart up. Epinephrine. Epinephrine is naturally released by what? The sympathetic nervous system. Yeah. It is a sympathomimetic, or a sympathetic agent. And it acts predominantly on the beta receptor side. You think back, you remember back when we were talking about these receptor sites, even as far back as AMT. You've got your alpha and your beta 2 receptor sites. Speed up the heart, cause contraction of the vascular system, and causes bronchodilation. And dopamine is actually a sympathetic agent. It is a chemical that is released by the sympathetic nervous system. We're using it to increase rate, which is going to be your chronotropic effects, and force, which are your inotropic effects. And it also constricts peripheral blood vessels, which is your vasoconstrictive effects. All right. Any questions?
Let's go back to 110.